Okay, we've been sent a case today. It is been sent in with the note, and the note is basically saying that it's a dentist who came to this Rhone Advanced User Training that I was training at, and if you've attended one of those, I allow you to submit some these cases in, and obviously also for those who are part of our workshop series, of course, they are always welcome to submit cases. So the note is that they want to put an implant in site number 30 and 31. They're having some issues based on the bone level, getting ideal plans, and wanted my feedback on it. So um, a couple of comments. My first question is I'm not familiar if the dentist who submitted this has CEREC or not. So if this is a CEREC office, my first suggestion would be this is an ideal case for an OptiGuide, which would negate the need for the bite plate. And the other, probably bigger advantage in this case for the OptiGuide would be that for the CEREC data would be that it would allow us to virtually wax up tooth number 30 and 31 to be able to plan those teeth in ideal occlusion so that we could use the restorative plan to design the implant location ideally. For those who don't have CEREC but do want that accuracy and that precision and that level of detail, the solution here would be to create what's known as a radiographic scanning appliance, where a laboratory or somebody in your office will do a wax up of 30 and 31, convert that into a barium sulfate duplicate, and go ahead and scan the patient with that in the mouth, attach the bite plate to it and scan it with the patient in the mouth. So let's go ahead and take a closer look here. So let's take a closer look. So the first thing I notice is that we plan for implants, and I'm just seeing a box here. So my preference is to always plan for implants where I can at least see the implant itself. So we'll go to here. Now you see how by selecting, instead of selecting generic, we select the brand name, we can actually see the implant itself. So, and the other thing also is I take the abutment off of here, so I'm going to put no abutment in here. I don't really care to see the abutment in these particular cases. So again, we'll change this one and see how when I click change implant, it shows up as generic. So we'll go here and put the BioHorizons tapered implant, which is what you planned, in this spot. Okay, and then one last time, we'll go ahead and take out this abutment since I forgot to do that. So there we go. So let's take a look. So what I would like to do is I'm going to back up for a second here and just kind of take you through what I would be doing if this were my case without the benefit of CEREC data. So one of the things that we can see here in this view is we see pretty well the arch form here. We see these lines that represent the insertion axis of the implant. And what I like to do, and just mentally typically I do this, but for this particular case I'm going to go ahead and draw this out for us, is what I like to do is kind of draw out my arch form. And again, this is some guessing involved in this, but we're dentists, we can pretty accurately know that this arch is not going to suddenly go out that way, that this is where it's going to be. So when I look at this in this manner, the first thing I notice is that number 30 is definitely a little bit buccal, and 31 is quite a bit buccal. In fact, 31, if it's placed where it's planned, is probably non-restorable. Again, unless there's something, if I'm way off here, which I don't think I'm way off here. So that's visually what I like to look at from this axial view right here. So let's go ahead and what I like to do when planning multiple implants, I like to start with the more forward implant and go from there. So again, as I teach in all my classes, my ideal is I always start with ideal, which in a molar site will be 5, and I typically will go to a 10.5 in this particular case, usually 11.5 millimeter implant, and then I'll plan ideally. So most of my planning, I'm taking a close attention here in the axial view. And what I will do, and I see this quite often here on patients, on implant plans, I should say, is that we try to drop the bone level to where the implant will be there. Now, my concern with this is this becomes an emergence profile uh, difficulty. One, now we're creating an area where this implant's going to be deep, which means that we're going to have more bone loss and more tissue hygienic issues. So my preference is to plan the implant ideally, which in this case would be at this level right here. Now, that also does mean that in this case I'm going to need to graft. Now, this may need to be grafted pre, or this may be grafted at the time of placement. It's really individually up to the individual person. But what this also allows me to see is that if I wanted to, I could go to a 12 millimeter long implant. Not necessary, but I think 10.5 is certainly long enough. But if we wanted to, we could. So I think that's important to plan this at the ideal level, add a little bit of bone right here. I'm going to come back to tooth number 30 here in a moment. The other thing that I like to take a look at here also is the occlusal plane. Now, one thing that we have a difficulty seeing is the occlusal plane here. So if we use this slider right here, we can slowly move this until we see our occlusal plane. Now, sometimes what people will do is use the opposing to measure the occlusal plane. And that is often good enough, but the problem when you have a bite plate in is we don't know how the patient's biting, if they're not biting. There's just many different things going on here. So I would say from an occlusal plane perspective, this actually looks pretty darn good. I may tilt this just a hair to the distal to get that a little bit more level, and I think that is probably about where I would like that to be. And now I'm pretty happy with that. I'm happy with the general location. The only thing I still think it is definitely tilted to the buccal here. And what I will do here is go ahead and tilt this back to the lingual. And now I think we're going to start having a more centered implant and giving us a more ability to restore this more ideally. And it may even need to come in just a hair more. So again, a CEREC design, a virtual wax up, or a laboratory scanning appliance would certainly make this a lot easier, but I'm starting to believe that that is nice. So now we see by getting a more ideal placement, now we're talking about just grafting a few threads. Certainly very doable and quite predictable in this case. I would definitely not drop the implant down like that. I would not be comfortable with that. So now once I have this other implant, the first implant idealized, what I do then is, as a good starting point, is I'll go to number 31 and I'll click change implant, and here I'll parallel that to number 30. And again, I'm going to go ahead and change this to a 5 by 9 millimeter implant and click OK, and now we have it idealized here, be parallel to the implant in site number 30. Now, again, if we go back here to the site number 30, we can see that, right here in the axial view, we definitely don't want to create implants like that. So what I'm going to have to do with 31 is I'm going to have to tilt this quite a bit to get that back into a more ideal position to where I think it's within the arch form there, kind of like that. And then I'll bring that up. And now here may be a situation where I'm willing to maybe kind of compromise on depth just a little bit, sort of that may go a little bit deeper here, but again, it would be very helpful to have the virtual wax up here. And then we'll take a look here. Move this implant over, and now we get into where this needs to be. Based on what I'm seeing here, this looks to be going up past the retromolar pad. I would likely bring this implant in a little bit closer and get something like this right there. So that starts to look a little bit better to me, and hopefully that kind of makes sense why that looks a little bit better to me now. I'm pretty actually happy with that. So I would look at that. And another thing to be able to look at is right here in the 3D skull view. If we are able to look at this, we can use this to level our occlusal plane and just kind of see where the implant is looking. So I'll right click and click long active slice, and we'll do it right there. And if we look at that, that doesn't look all that horrible there. Assuming that if we get our patient straight ahead here, maybe these implants are tilted a little bit to the distal here using that view. So what I may do is come in here and think that the implants are tilted to the distal, I may just go ahead and tilt just like so. And that's starting to look a little bit better there actually. And using the 3D view, move that over to create the space I need away from the adjacent tooth. And then I will come in here and I will tilt this until it visually looks relatively parallel. And since we're not splinting these, I'm not worried about having absolute parallelism. And now we can create the space that we need between the implants. And remember, between implants, we need approximately 3 millimeters of space between implants. And there we go. And now I think we have a much better plan here. I think in looking at the axial view here, we can see that these implants seem to fall in line with the arch form. You know, we may just be a hair lingual. I'm guessing a little bit here. So, you know, if anything, I can just tilt that a little bit there and tilt that a little bit there and go. And another way I also look at this sometimes is I'll look at this from an axial view here, and you know I can see here, this shows me a lot actually. It shows me that my two implants, one is tilted to the buccal and one is tilted more ideally, and by ideally what I say is that lower molar teeth are tilted to the lingual. So more than likely what I would do on tooth number 30 here is I would go ahead and tilt this from the apex back to the lingual there, and now those are starting to look a little bit better there. And based on that, I would still say that maybe we need to come out to the buccal just a bit and come out to the buccal just a bit there. And now we're starting to look like we have a pretty good idealized plan here. I'm starting to like that quite a bit. So hopefully this has been helpful. This case definitely needs some grafting. I think compromising it any other way wouldn't be ideal here. So I would definitely graft this case. I think it's, again, with some training, this is a relatively straightforward case to do some grafting on. Thank you for submitting the case.